Right.
Okay, we're recording, guys.
Okay. All right, let's see who we got left. Lauren, can you name another vein for the arm?
Radial. It's
Radial,
a
good.
deep vein.
And then Megan, another vein for the arm.
The ulnar vein,
Ulnar, good.
and that's deep.
Can anyone tell me where the radial and ulnar are located in the arm?
The radial on the side of the thumb and the ulnar on the inner part of the arm.
Perfect, very good. And they're both in the forearm, so below the elbow. What else are we missing?
With the innominate
Innominate, good.
vein
Yeah,
being one.
there we go.
What about the median cubital vein?
Yep, so that one I put down here, the median antecubital vein. That's actually superficial.
Oh, that's superficial. Okay.
Yeah, so that's considered a superficial vein. Looks like we're just missing one. What's in the neck?
Would it be the jugular?
Jugular, very
The
good.
internal and external?
Internal jugular, yep. IJV.
Is the external jugular part of it?
So yeah, so the external jugular, it is seen, but it's not typically imaged as part of your protocols for exams. The main reason being is that the external jugular vein, it drains the muscles of the face, whereas this is draining the brain. So that's the main reason for its importance, because then you can have pressure build up backing up to the brain, actually. And typically the internal jugular vein is much larger in caliber. So that's the vessel that doctors will try and actually puncture when they're doing central lines. Sometimes in the hospital, you see a patient that has a line in the neck, and that's the internal jugular vein that they're going into. And also, as you were imaging, it's kind of a straight shot down into that innominate. So it's easier for the doctors to run that catheter when they go into the neck, into that innominate, and get into that right side of the heart.
And that's called the central line?
Central line, yep. Central line.
Is that different than a PIC line?
A PIC line is as a form of a central line. So a PIC line is a more specific that, they typically is in the arm, the upper arm, where they access typically the basilic vein and then kind of snake the catheter through the subclavian, through the axillary subclavian. So this is kind of like your pathway. So I kind of just started from the neck and just worked my way down. So internal jugular vein, innominate, subclavian, axillary, brachials, radial, and ulnar. So those are all your deep veins. Then you have your superficial veins, your cephalic, basilic, and median antecubital vein. All right. See, I feel this is a lot better than those PowerPoints.
Yes.
Oh God, yeah, I really like it.
I can see people like shaking their head. I'm like, yeah, we're getting it.
All right, so we're gonna go on to the legs. So how familiar are you guys with the anatomy of the legs? Have we
I feel like
done-
I know arteries pretty well, but not the.
You know arteries well? Well, if you know the arteries, then the veins shouldn't be too hard for at least for the deep, because they share pretty much the same names.
Okay.
So does anyone want to volunteer, try and give a vein
Femoral
for the
vein.
leg? Anyone? Morgan? Vein for the leg? I'm sorry?
Femoral vein.
Femoral vein? Okay. Now, is that deep or superficial?
Deep.
Deep, good. Let's see. Kimberly, vein for the leg. Kim?
Popliteal.
Popliteal, good. Is that deep or superficial?
Deep.
Deep, good. Yes. Elena, you want to give us a vein for the leg?
Great saphenous vein.
So is that one deep or superficial?
Superficial.
Superficial, perfect, good. Line, GSV. All right, so what do we know about the GSV? Because that's an important one. We'll stop right there for a second. So
The
GSV,
longest.
I'm sorry, longest?
The
Yeah,
longest.
exactly, very good. Longest vein. So with that vein also, that's the one that we typically, doctors harvest in order to use for bypasses. So it can be used for bypass, coronary bypass, bypass for the heart. Can also be used for bypass for arteries in, say, the legs. So if a person has really bad peripheral arterial disease in the legs, they'll take that vein, they'll remove it, and they'll actually flip it, invert it, and then transplant it back in the leg and create a bypass to get around any blockages in the artery. So it's longest vein used for bypass.
And you said that's a superficial vein?
It is a superficial vein, yes. Yep.
Oh.
And where do you see it in the scan?
Yeah, so GSV begins high up in the groin where you see the junction connecting to that common femoral. And it runs along the medial aspect, the inside of the leg. Someone else want to give me another vein for the leg?
About the tibial.
Sure. Posterior tibial. Yeah. So I'm going to label it PTV, posterior tibial. Deep or superficial?
Is that deep?
Deep, good, yes. Aretha, you want to try another vein for the leg?
Would external iliac be one? I think
Sure.
that should be one. Deep.
Yeah, that's deep. Yeah, definitely.
Okay.
So external iliac vein. I'm just going to abbreviate it. Like external iliac vein. So what's one that would come between the external iliac and the femoral vein?
The deep femoral vein. The deep femoral vein.
I'm sorry? Deep femoral vein?
Yeah.
Put that on here. That's a deep vein.
Common femoral vein.
Common femoral. Yes, that's the one we're looking for. That's the big one. All right. So I'm just kind of going in order, like beginning superior and working our way inferior. So we have our external iliac vein, which passes underneath the inguinal ligament. So I use the inguinal ligament as kind of like the demarcation between the external iliac and the common femoral. Ligament. Inguinal ligament. So as we're working down the leg, we have our external iliac vein, which becomes the common femoral vein. Then the common femoral vein splits into our deep femoral vein and femoral vein. And the femoral vein becomes the popliteal. And then popliteal becomes, we have one more vein where the popliteal splits. Actually, we have two more in the calf.
Peroneal vein.
I'm sorry?
The peroneal vein.
Peroneal veins, yep.
Anterior tibial?
Anterior tibial, yep, very good.
And the perineals become the anterior tibials, or the post, or what? There's just
No, that's fine. So with the popliteal vein, there's an area where you actually, it's called the trifurcation, where it actually splits. So the popliteal vein is going to split and the anterior tibial take off. And this becomes your, what's called the trunk, or the tibial peroneal trunk. You'll often hear it referred to. So trunk, or put over here, tibial peroneal trunk. So it's this tibial peroneal trunk. I think in Christianity, they have their own image for this in their DVT study, where they actually get a compression picture of the tibial peroneal trunk. I know in some of my labs in my hospital, we have a dedicated popliteal image, showing with and without compression. And then we kind of angle our transducer inferior a little bit more, and we look for the split into the tibial peroneal trunk. So this tibial peroneal trunk, as you move down the calf, will actually split into your posterior tibial and peroneal veins. So behind the knee, you have this called the trifurcation. So these anterior tibial are more along the outside anterior portion of the leg. Typically, we don't image the anterior tibial veins as part of your normal DVT study. Can anyone, another superficial vein?
The small
The
saphenous.
Small saphenous, yep. Small saphenous or lesser saphenous, yep.
We have a question here too. The greater saphenous vein, is that the nose of the Mickey Mouse?
That's,
Someone had that.
oh, someone had a question.
Yeah.
Is that the nose of the Mickey Mouse?
It's the great cephalic vein, the nose of Mickey Mouse.
So
like I don't even know if that's not like
I think
technical.
it's one of the ears. It's one of the ears, right?
It's the ears.
yeah.
I mean, I don't know what picture of Mickey Mouse you guys have seen. Was it like from the side, or was it like from the front with the ears?
I guess it depends, right?
We'll be able to explain better when we're scanning
Yeah.
and show you. Because I know what you mean from that last comp that we did.
Yeah, that's exactly what I'm talking about.
Mm-hmm.
So if I'm in a transverse view, so this is your common femoral vein,
Yeah.
and then greater saphenous is this guy.
Okay, I feel like that's the nose.
It
Yeah,
is,
give him a
because when
big-
we're
give him a
scanning,
big
like
nose.
we show the connection.
Yeah, who knows?
Cool. Thank you guys. All coming together.
And then maybe would it be the common femoral artery? That was what I was thinking. Like a Mickey Mouse, like common femoral, greater saphenous, and
So
artery.
I don't know.
So I found
So
I
for
found
me-
the picture you're talking about, Morgan.
Oh, yes.
It goes, it's the superficial femoral artery, I believe. So
Yeah.
and then it's
And
the
those
deep
are the
femoral
ears.
artery, the common femoral vein, and then the nose is the great saphenous.
Yeah, so the ears are the superficial and the deep.
The
right?
two femoral arteries. If you want, I can take a picture and like send it in the group chat to everybody.
That
Sure.
would be amazing.
And I have an Ed puzzle of lower extremity venous ultrasound whenever you're ready.
So then just a couple more vessels actually for the calf. All right, so this kind of demarcates, you know,
Soluble
eye. And calf. So these are all deep veins now. Got our superficial down here. So I'm just gonna kind of erase this for a second. Is that okay, or?
Yeah,
Yeah. So just for a couple more deep veins that we need to note for the calf as well. So we have the
Yes.
gastrocnemius vein. I'm just
Soluble.
gonna label gastroc vein or gastrocnemius vein. And we also have the soleal vein or soleal sinus. Sometimes you're seen to refer to as the soleal sinus. So the gastrocnemius vein and soleal vein are both also considered deep veins because there is a corresponding artery with that as well. So soleal vein, that was going to be a branch off of either the posterior tibial or peroneal veins. So this one, the soleal vein, you'll typically see around mid-calf. So when we get in the lab and start scanning this, I'm going to show you exactly where to locate this vessel. And it's located within actual the soleal muscle. So that's actually a muscle of the calf. That's where the majority of these vessels in the calf get their name. So then the gastrocnemius vein is within the gastrocnemius muscle. And this one is a branch off of the popliteal vein. So this one, you'll see its origin when you're in that popliteal fossa behind the knee.
Hey, Dan.
Yeah.
Just want to make sure I'm reading this right. So it says the soleal, it says it branches off the posterior tibial vein and the peroneal vein.
Either one. It could be one or the other.
Okay.
I've seen in our textbooks, it says it could branch off either one. To be honest, I've seen both. So it'll either come off one or the other. Another thing too to remember about that soleal vein, it's actually the most common location for clot to form. So that might actually be a potential registry question. It'll ask, which is the most common location for deep vein thrombosis to occur. It's actually in that soleal sinus or soleal vein. But in general, DVTs typically occur more often within the vessels of the calf. So it's important to, become familiar and proficient in scanning these calf veins because that's where you're going to find most of your clots. Does anyone need me to keep this up still or can I erase? Everyone's good? You're okay? Thumbs
I'm
up? Yes, yes, yes.
Are you good if I send this video out?
What?
It's a lower extremity venous tutorial.
Sure, sure, if you want.
So you'll see I just put a link in the chat. So that's one of those ed puzzles. So it's a lower extremity venous ultrasound tutorial that kind of goes through the protocol. So if you guys wanted to do that now, it's about 7 minutes. And I'm not sure because I've never assigned those before. So if these are easier to do alone or together, just kind of like let me know what you guys would prefer to to do these all at once. I think this one might be better just on your own, kind of go through it at your own speed.
Welcome to this Radiology Nation ultrasound video tutorial. In this video,
about that, Dr. Cano?
would do the entire.
Is everyone finished or are we still working?
Done.
I'm finished.
I'm done.
So do you want to go through a couple of the questions, just in case they had questions on that video?
Sure, yeah.
So what was the location of the adductor canal?
So abductor canal, that's in, for me, it's the distal third of the thigh. So if you have a patient's thigh, like, kind of like half. So you'll have your femoral vein running down your thigh. So the abductor canal for me typically begins about here. And it's just like superior to the knee. So this distal segment of the femoral vein runs within the abductor canal.
Along the medial aspect.
Yeah. So that's along the medial aspect.
It's like hard to push there.
Yeah. Yeah, typically the vessel's harder to compress there because it's running within that abductor canal. And also too, to remember, if a patient had any trauma to that leg and the muscle becomes swollen, it can actually compress the vessel too.
What about, have you ever scanned a patient with their legs hanging off the bed?
So I would typically do that if I had to do a reflux study. Sometimes when we're testing, you know, the competency of the valves, I'll have the patient either stand or hang their legs off the bed. It's something that we do too when we do venous plethysmography. We put a pressure cuff on there and we're testing, you know, refill, and we're looking for reflux as well for that. But no, like typically I would just try and like angle the stretcher or angle the bed, you know, lower the feet, raise the head. I don't know. For me, like most of the patients we're scanning, you know, are typically elderly, and you don't want them sitting on the edge of the bed. Like God forbid they get dizzy or fall on you or tilt or so.
What about that anterior tibial that they showed in the video?
Okay. Yeah. So the anterior tibial vein, it's not something that's typically imaged within the laboratory. Normally we focus on the anterior tibial vein when we're scanning the arteries, you know, because that's a critical artery, because that, you know, it goes down the leg and becomes a dorsalis pedis. So that's one of the areas, you know, that where doctors are feeling their pulses in the lower extremities. So that anterior tibial, it's primarily imaged when we're doing arterial studies. I mean, if there is suspicion, like say the patient had like a CT with contrast and runoff and they're assessing, you know, circulation in the legs, and they happen to notice something in the anterior tibial veins, they may order, you know, a lower extremity venous duplex exam to look for clot there. So, I mean, it's good to become familiar, you know, recognizing where to go to scan the anterior tibial veins, but it's typically not something, you know, that's going to be asked of you in the clinical setting.
And then they augmented that vein too. So you want to talk about augmentation to be able to see them better, maybe?
Yeah, so that's a good question. So can anyone tell me what our body uses to circulate blood? So like in the arteries, what is the driving mechanism for blood in the arteries?
So not the heart?
The heart, exactly. So the heart is that muscle that's pumping that artery, pumping the blood through the arteries. So in the veins, we don't have that pumping mechanism anymore. We don't have that influence of the heart because the blood is transitioned from the arteries, you know, into the capillary bed system and then transitioned into veins. So once we get that transition through the capillaries into the venous system, we no longer have that influence of that heart to pump that blood. So instead now the body needs another mechanism to pump that blood. So the body relies on the heart calf muscle pump or skeletal muscle contractions, moving our muscles, our arms. So it's that muscle contraction in the body that allows the blood in the veins to circulate.
The inspiration and respiration too.
Exactly. So yeah, that if you think about it, the diaphragm is a muscle also. So that's going to help exactly create those differences in pressures that we have in the body. So that diaphragm comes up, pushes, you know, the organs and like creates those differences in pressure. So respiration and skeletal muscle contraction, those are the two main factors that are going to circulate blood. So augmentation, when we squeeze that calf as part of the exam, we're simulating a muscle contraction in the leg. So the veins in the calf, they typically don't have that influence of the breathing of the lungs to help circulate it. So you lack something called spontaneous flow. So calf veins, so they typically they're not spontaneous or no spontaneous flow. So basically what that means is that the blood isn't going to really circulate on its own. So if you're just lying there, not moving your muscles, typically that blood flow isn't going to circulate, especially in the elderly patients. When you're young, you can see some spontaneous flow. It's not nearly as fast. Sometimes the ultrasound machine actually isn't even sensitive enough to pick up that flow. So with the calf veins, that's typically why we do the augmentation. So we can get flow in those vessels and able to image flow in those vessels.
And then is that why people in the ICU have the cuffs?
Yeah. So has anyone like been to the intensive care unit or seen inpatients that we scan portably for DVT studies? Has anyone? Yeah. Did you ever notice like those cuffs that they put on their legs that inflate? So in the hospital setting, we have like these, they almost look like the PVR pressure cuffs that we use. So they're on the patient's calves on the legs, and they intermittently inflate with air to kind of keep that circulation going to prevent blood clots from forming.
I have a question. So you're
Sure.
talking about doing augmenting in the calf. Can we do that also like in the arm? Like I feel like I was scanning Miriam and I had her one vessel open,
Yep.
but it wasn't filling at all. So I wasn't getting any pulse wave and I was like, I don't know what I'm doing.
You can, yeah, you can absolutely augment in the arm, definitely.
Okay.
Yeah, it's the same principle, same theory, you know.
And then the other question is
So you basically
Which
like the question in the thing.
you just like Dan, you like augment, where would you compress? It just depends on what you're trying to fill.
I'm sorry, I couldn't understand.
Like when you're augmenting the arm, like where would you compress or the leg? Like it just depends on what vessel you're trying to fill.
So augmentation in the leg is typically done in the calf.
Okay.
There we go. So I'm going to squeeze along the medial portion of the calf. Give a little squeeze. So basically you want to do it along the course of the vessels. So along the course of the posterior tibial and peroneal veins here in the calf, along the medial calf. So you're going to squeeze. It really doesn't take much pressure.
Okay.
So when we get in the lab and practice augmentation, like really all you need are 2 fingers. Like I've seen some techs really like squeeze hard like the calf like that. You really don't need it. As long as you're along that course of the vessels, just putting a little bit of pressure there will give you augmentation that you should be able to see all the way up when you're imaging the common femoral. So that is part of the exam as well, to demonstrate that augmentation. Because in theory, so if I have my probe up and I'm imaging the common femoral and I augment down here and I see that, you know, spike or surge of blood going back up to the heart. So I got my normal, we'll put it back up. So if I get my normal, you know, venous waveform, I augment and I see that, you know, sudden spike of blood or surge in velocity, I can basically infer that there's no blockage in the vein from where I'm imaging from to where I'm augmenting.
And then the only other last thing was what if a clot is found? Like, do you keep going in your department versus?
Yeah,
other places?
So for me, yes, I would absolutely keep going with this study. It's important to know exactly how much thrombus is within the leg.
You can't hear me, so I don't know why I asked.
Oh,
Sorry.
no, Kathy was asking if we find a DVT, do we continue with the study or do we just stop there? In all my labs and all my scanning, I absolutely continue with the study. It's important to get a good idea just how much thrombus or clot is within the legs. It gives the doctors an idea of just, how aggressive they have to be with anticoagulation and medications that they have to provide to the patient. In addition, you can have a little bit of clot, say up high in the common femoral. Femoral vein could be okay, popliteal vein could be okay, and then you can find some more clot down by the calf. And if you had just stopped, you would never have known. You just see that one segment, So you're not really getting the whole clinical picture of what's going on. In addition, you could potentially miss other pathology too as you're going down the leg. So there are other things that you visualize, within the lower extremities as you're imaging the veins. But I actually have some slides for those, on Lily's PowerPoint that we're going to go over a little bit later, like some of the other things that you might encounter as you're doing lower extremity study. So just a couple of key terms, that you need to remember. So the first term is clot. So a clot is anytime blood coagulates or sticks together. So this is the coagulation of blood. And another word is thrombus. So then thrombus now refers to clot in a vessel. So when we say that a vein is clotted, this process is known as thrombosis. So the next word is emboli or embolus. So emboli or embolus, this is the term that we give to clot or to thrombus. That has moved or broken off from the veins. So it's broken off from the veins and it's moving through the body, or through the venous system, moving through venous system. Spell the venous system. Can anyone tell me where the final destination is for clots in the veins, where they're all going to wind up?
Wouldn't it be the IVC?
I'm sorry?
Be the IVC?
IVC. Yeah, so they'll go into the IVC, and once they get into the IVC, they're going to go up.
The lungs.
Lungs, yes, that is the final destination of all clots in the veins. So any venous clot is going to wind up. Ends in the lungs.
Would that be called a pulmonary embolism, right?
Exactly. Yep. That's where we get the term pulmonary embolism. So you have your clot in the veins or thrombus. The thrombus then breaks off and becomes emboli. The emboli are the clots that are traveling through the body. So those emboli, their final destination, they're going to enter the heart, the right side of the heart. So enter into the right atrium, travel into the right ventricle, and the right ventricle is going to pump them right to the lungs, through the pulmonary arteries, right into the lungs. So the final destination for any venous clot is the lungs. And that's the condition called pulmonary embolism.
This might be a dumb question, but is it like possible for it to get stuck in the heart?
That's what I was just about to
Get
ask.
stuck in the heart?
Yeah. Or is that like not possible? I don't know. I've just like, is it possible for it to get like stuck in like a valve or something in the heart? I don't know. That might be a dumb question. I have no clue.
No, not a dumb question at all. A lot of that would depend on the patient's cardiac status. So, I mean, if they have a heart that's not really pumping very well, you can actually have clot form within the heart itself. So, I mean, we're going to learn in an echo when a patient has a very low ejection fraction or low EF, and then the heart's not contracting very well. It's similar. You're going to wind up with clot formation within the chambers. Particularly on the left side of the heart, there's an appendage called the left atrial appendage. That's kind of like a nice little pocket where clots like to form. But the dangerous part, when it's in the left side of the heart, if it breaks off and travels and becomes emboli again, instead of going to the lungs, it's going to travel into the arterial circulation. So when it leaves the heart through the aorta, one of the first places it encounters, are the carotid arteries and can go to the brain and create stroke.
Okay. I got it. Makes sense. So they can move, but like normally they'll just move from the heart to the lungs.
Yeah, typically it goes to the lungs, but clot can get stuck in the heart. I mean, it can get lodged in the vessels leading to the heart, so you can get clots stuck in like the inferior vena cava and the superior vena cava. I mean, these are very extreme circumstances where typically you're going to need some sort of medical intervention. So pulmonary embolus or PE. So you'll see that term a lot in the hospital, PE.
Don't call pleural effusion a PE.
Yeah, Kathy's saying don't call a pleural effusion a PE. So thrombosis is the name of the condition for clot occurring within a vessel. So that's how we get our term DVT, deep vein thrombosis. So now we're going to move on to some signs and symptoms of DVT. Does anyone have any ideas? What could be some signs and symptoms?
Shortness of breath.
Very good. Yeah. So shortness of breath. Typically, we'll see shortness of breath once the clot is actually embolized and gotten to that lungs. So this is more of a sign and symptom of a PE, but it is an indication for doing a lower extremity duplex exam.
Claudication.
Claudication. So claudication is more a term that we have to associate with arteries. So that's arterial circulation. But along those lines of claudication, pain.
Okay.
So lower extremity pain.
Swollen.
Or tenderness. We can say lower extremity and
Swollen.
upper extremity. We can just do extremity pain and tenderness.
Would you have any like numbness or tingling or anything like that?
Not really.
Not really.
Numbness.
That might come with arterial.
Yeah, typically
Okay.
numbness is more an arterial symptom.
Okay.
I know the patients that I've had that, you know, have DVTs, they almost explain it to me almost like it's just like a weird sensation, almost like their leg just feels heavy, like there's a heaviness to their leg.
Okay.
And they can't really describe it. I mean, I have some patients, you know, that are in tremendous amount of pain, but it can definitely vary the level of pain and tenderness. I mean, typically they describe more as tenderness, the actual pain itself, like most of the patients that I have. Yeah, tenderness. All right, so
Swollen of the limbs.
swelling, yes, very good. Absolutely.
Inflammation or
Remember too
redness.
about swelling is typically it's unilateral. So one side becomes more swollen than the other. So that's can usually be a telltale sign of a DVT. Patient comes in, one leg is swollen, the other leg looks normal. Like, okay, all right, something's going on here. Because if it's just normal, like edema, normal, like, you know, water within the tissue, both legs are typically going to swell evenly. The swelling, you'll learn to realize it's a little bit different. It's a harder swelling. It's not that pitting edema where you stick your thumb in the patient and you kind of leave your thumbprint. You know, this swelling's a little bit different. But you'll learn to realize that or appreciate that when you get into the work, when you get into the field.
Is it because it's more acute swelling? Is that why?
Yeah.
Or they can't hear me.
Oh
Sorry.
no, yeah. So the swelling is like more of a result of like buildup in pressure within the vessel and like the backing up of the blood flow, as opposed to water actually coming out of the vessels into the tissue. So it's a little bit different.
Leaking from the vessels.
Yeah. But,
Mhm.
all right. So we have
Inflammation.
shortness of breath, pain, tenderness. Another one is discoloration. typically you wind up with redness in the leg. You can also have cyanosis or a little loss of color, like the leg gets a little purplish or blue. And this is typically seen with extensive DVT when the patient has very severe DVT going from iliac IVC extending all the way down the leg. You can also sometimes see the foot looks a little cyanotic or a little, you can say purple. It's a good description of color. You'll get a purplish. But more common, you'll get redness. There'll usually be warmth to the leg. The leg might feel warmer. So another thing that might occur, patient may become tachycardic. So tachycardic is an increased heart rate. Does anyone know what constitutes an increased heart rate? Above what? Or like normal heart rate range? No?
190? No.
It's
So
it's greater than 100, right?
greater, yeah, yes, very good. Bonus point.
I mean, I'm CVS, so.
So yeah, so tachycardic would be considered anything over 100 beats per minute. Beats per minute. So good. Is it okay if I erase this, or you guys still red? Still red?
I'm good.
Good. So there's something else called a palpable cord. So this is more common for upper extremity, since the veins are superficial and you can typically feel them. They're not as deep within that muscle. So a palpable cord is you'll feel like a hard, like the vessel actually feels like a cord within the arm. So sometimes a nurse or a doctor might feel the actual vein, they can feel that it's thrombosed, it's hard. So that can become an indication, for doing an exam.
And you said that's only in the upper arm?
Oh, not upper extremity. So upper.
Okay.
Extremity, sorry.
More commonly felt.
Yeah, more commonly felt. Yeah, in the upper extremity. Yeah, so it's more commonly felt in the upper extremity.
And that would be because the lower extremities are deeper.
Yes, yeah. So your lower extremity deep veins, they're running deep within those muscles. You typically cannot palpate a deep vein in the leg. Now, superficial vein, you'd be able to palpate. So, I mean, this could be a potential indication, for doing an exam if they want to rule out superficial phlebitis, thrombophlebitis, if you want to assess like the greater saphenous vein or the small saphenous vein, you could do that for the legs.
So question,
Sure.
it could be done in both the upper and lower extremities, just for the superficial veins?
If feeling a palpable cord.
Yes.
Yeah, so you should be able to potentially feel a palpable cord in the leg. Again, it also depends, on the limb size too, on the patient. But normally I typically see this indication when they're ordering upper extremity venous studies. I rarely see this as an indication or a sign or a symptom for a lower extremity study.
Okay.
This is another term that you might see in the hospital. It's called a Holman sign. So this is kind of an old school method that doctors used to use to determine, if a patient could potentially have a DVT in the leg. So what a Holman sign refers to is when, I'm gonna put this down a little bit. So the doctor will do an evaluation of the patient and they'll have them dorsiflex their foot there. There we go. So we can see, so they'll have the patient kind of hang their leg and go like this with their foot. It's called a dorsiflexion, and it kind of like tightens the calf muscle. And if a patient, indicates that they're having pain on dorsiflexion, that could potentially be another sign of a DVT. That's more of an older school, like some of the old school doctors will order a study, based on Holman sign. Normally, you don't see that too much anymore. That's another term that could potentially come up for you, Holman sign. So this is for lower extremity. So now I was thinking of getting into some of the slides that Lily has, of actually showing, DVTs and some of the slides that were in the PowerPoint. But do you guys want to take like a 5-minute break? Yeah. All right.
Yeah.
Sounds good. I need a chalk. You got no chalk?
We do,
Yeah,
yes.
you do.
We do.
Lots of crayons.
Yeah, boxes on the top, no problem.
Nice.
I'm trying to figure out, look how,
Hey, Dan, I don't know if you could hear me, but I can't hear you.
Me too.
It's kind of funny with my mask down, you can't tell if I'm talking or not.
Oh,
I was
no, I
just-
think he was
I was
muted.
just writing on the board, just preparing.
Oh.
I was gonna go to like some of the PowerPoint images, but I
Okay.
decided, like I want to hit on this point first because it's important before we actually, to really fully understand, DVT too. We kind of left out this point too. So this is a very key term too for your registry.
Okay.
So this is it's called virtuous triad. So these are basically the three main mechanisms that are going to cause clot within vessels, particularly in the veins. That's the other thing to remember. Clot within a vessel typically happens in veins. The blood flow in the arteries is it's circulating too fast for it to really get a chance to form into clots. So the majority of the time when we hear the word thrombus or clot within a vessel, we're referring to veins. All right. So, all right. So the first term is stasis. So that refers to static, like blood flow is not moving. So we have to think of different things that can cause stasis or prevent the blood from moving. So the first main thing is obvious lack of movement. So when we think of lack of movement, those are patients that are bedbound. Those are also people that, could potentially have been like long periods of long travel. Like if you get on a plane for a long period of time or a long car ride, those are things that could cause you to have lack of movement. Paralysis, say you can't even move your leg. Another thing that can cause stasis would be proximal compression. So if you have something that's higher upstream, that's compressing the vein up there, you're going to impede that blood flow through that vessel. So that's going to cause stasis of the blood too. So some things that could cause, proximal compression could be, a mass or a tumor. You can also wind up, oh, that's okay. Down. Oh, thank you. You can also get proximal compression through your own anatomy, through like muscle and bone. So, if you like you're lying the wrong way, or if you, put yourself in a position where the tendons, the muscles, the bones, the ligaments can actually compress your vessels as well. So those are the two main things that create stasis. Actually, no, we can also add cardiac. And cardiac function. So now I'm going to move over here to trauma. So trauma refers to injury to the endothelial, that inner lining of the vessel. So different things that can cause trauma or injury to that inner lining of the vessel is actual physical trauma or injury. We'll say physical trauma. So you hit yourself, you're involved in an accident. Physical trauma. Can anyone think of like an obvious one that would cause injury to a vessel, or the most common? Put it that way.
Puncture, like.
Exactly. Yes. Puncture. So anytime we draw bloods or draw labs, you know, we're injuring that vessel. So we're creating trauma to that vessel. It's a venous puncture. Oh. Yeah. Yeah. Well, I actually thought of one more too for stasis. Under for stasis under proximal compression, I just thought of one more. We can put under here a baby. This is actually a common occurrence, so we'll get into that a little bit more. But pregnancy with the baby growing inside the mother will actually cause proximal compression because it's sitting, you know, over that inferior vena cava. It's sitting over the common iliac. So as that baby grows, it can compress those vessels and cause proximal compression.
And isn't that why they have pregnant mothers like lay a certain way in bed?
Yeah. So Kathy was just saying, you know, that oftentimes the doctors will recommend that a pregnant woman will lie on her left side in order to ensure that she's not compressing that the inferior vena cava. So if you think about your anatomy, you know, you have the inferior vena cava running down the right side and the aorta on the left side. So they'll have the patient turn on their left sides, you know, to kind of have that baby shift over towards the aorta, because that's much harder to compress than a vein. So if they're lying on that right side, they could potentially be compressing that IVC. And that can cause, you know, dizziness, lightheadedness, because you're not getting that venous return coming back up. All right, so we have physical trauma, venous puncture. All right, so then we have the main thing called hypercoagulability. So this is when the body is in a state in which it's more prone to producing clots. There are a lot of different things that could put the body into a hypercoagulable state. Different medical conditions like certain types of cancers. So this is particularly cancers of like the digestive system. So like pancreatic cancer, esophageal cancer. We can put pancreatic cancer, lung cancer. Lung cancer is another big one. So pregnancy itself actually puts a woman in a hypercoagulable state as well. So not only do you have that baby growing, which can cause compression or stasis, the pregnancy itself puts the woman in a hypercoagulable state. So this is in part doing like it's a way for the body to help prepare the woman when she's about to give birth, so that she doesn't hemorrhage out and bleed out. That the body's going to increase clotting factors within the blood to help prevent that after during the delivery. I think you're also going to learn too that, you know, during pregnancy, blood volume also increases exponentially as well within the body. So as blood volume increases, you know, you get more red blood cells within the body as well. So that blood becomes more viscous. So that's part of it, you know, leading to that hypercoagulable state. And then there's certain diseases. The big one is called factor V Leiden. So there are certain autoimmune diseases that can cause someone to become or more susceptible to developing clots. So the big one that you'll often hear, you know, patients that have, you know, recurrent DVTs, they have a history of a disease called factor V Leiden. So under here, other autoimmune diseases that could potentially cause it. You have antiphospholipid syndrome. Protein S and protein C deficiency.
Are these under factor V Leiden?
No, these are just other, yeah, other separate conditions that put a patient in a hypocoagulable state.
Dan, will you move your camera down?
Oh, yeah.
Thank you.
No problem. Protein S, what is it? And protein C deficiency. So all these are actually on those PowerPoint slides that Lily gave us, that go into more detail. So, if you need to go back and review and look at any of these, like, autoimmune diseases. I mean, she it gives a bunch. I mean, in terms of your boards, the big ones, is the factor V. That's the big one that you'll most definitely see on your registry exam. And then just realizing, other things that can cause, like different types of cancers or make you more susceptible to developing clots, pregnancy, and then there's autoimmune diseases like factor V. All right. So just to summarize, so the three main driving factors that create blood clots, we have hemostasis, lack of movement of the blood flow, hypercoagulability, different conditions that cause the blood to become more susceptible to developing clots, and then trauma to the actual vessel. So those are the three components of Virchow's triad. So now we're going to get into some of the slides actually looking at clots. So here we could see, like your classic presentation, of unilateral swelling. Patient comes in, they have one extremity that's significantly more swollen than the other. Like this is really an exaggeration, like typically you're not going to see that large of a difference, but it is noticeable. This, is your classic example. All right, so we have our internal jugular vein. So here's our classic transverse picture where you get your artery and then the vein located more anteriorly above it. And you could see, within the vessel, you have some intraluminal echoes and absence of color flow when you put your color box on. So here we got another image now of the subclavian vein with and without compression. So you could see your artery. This is a transverse along the orientation of the vessel. So we remember with the subclavian, so when our probe is in transverse, we actually have a long image of the vessel. So this would be with our probe in an orientation of a sagittal or in a long orientation. Here we have an image, again, of axillary vein with DVT. You can see your artery, your vein, your intraluminal echoes. There's no compression of the vessel. All right, so this is now an image of the common femoral vein. So here we could see again, when we put our color box on, we're getting partially occlusive DVT. So there's partial flow getting around the central thrombus. So here we see what's called a free floating thrombus. So with this clot, you might actually see this kind of flopping around when you're scanning in real time. So this might actually be moving within the vessel. Like when you come down the leg, this clot might actually be moving around with the blood flow. So these could potentially be a source of embolus because it looks like it's ready to break off and travel. And as you can see, you're getting color flow around the vessel. So this would be considered a partially occlusive DVT. And this is also acute. Here we go. Here's that Mickey Mouse. So we have our common femoral vein, and then we have the superficial femoral artery and the deep femoral artery. This is again with and without compression. So this picture here, this is a large lymphocele. So this is this big anechoic structure here. So this is actually causing compression of that vessel. So this is, like a mass or a lesion that could cause that proximal compression. So what this does, it actually causes you to lose the pulsatility and the respiratory variation that we get from the lungs and from the heart. So when we have this large mass or a large structure causing proximal compression, our waveform is going to look more monophasic. It's going to be a flatter waveform. So over here, this is showing the common femoral vein on the left side, and this is the right waveform. And then this is that mass in the right pelvis that's compressing the iliac. So this is why when we have a unilateral or a one-leg exam that's ordered in the hospital, we always take an image for the contralateral or the opposite common femoral vein, mainly to compare those waveforms. So then we could rule out, that there's no proximal thrombus that we potentially might not be seeing. So we want to look for a similar waveform when we're doing a unilateral exam. So when we go to that, if it's a one-leg exam, we'll go to that other common femoral on the opposite side. We'll do our compression pictures and we'll do our long color. And the most critical part of that is that Doppler waveform. So this picture shows an occluded superficial femoral vein or occluded femoral vein. So you can see down here, this is your femoral vein. This other vessel here is actually a duplication or a collateral vessel. So oftentimes when a patient's had a DVT, they'll start developing these little collateral vessels in order for the body to get around this central thrombus. So these little collateral vessels will start to open up. So don't be fooled, you're imaging, you see your femoral artery and you see a vessel over here. All right, this is good, this compresses. And ignore this, because this is your main vein. This is the central clot. So there's still DVT. This is showing the popliteal vein again. So you have your artery posterior, your vein anterior, and then this is with and without compression. Now we get a long image of the popliteal vein. You could see you get color flow in the more proximal segment. As you move distally, it becomes thrombosed. So this is an image showing the valves kind of stuck together. So this whole vessel is thrombosed. So those valves now become embedded in the clot. So this is actually kind of an important takeaway with patients with DVT. You know what, we will go back to me. So when a patient has a DVT, you know, the entire vessel becomes thrombosed. And within those vessels, you know, we have our veins. So as the DVT starts to resolve, unfortunately, a sequela or result of the DVT is we oftentimes have damage to these valves. So more often than not, the patients are going to develop reflux or venous insufficiency after the clot resolves. So after the clot resolves, unfortunately, these valves become damaged, and then we get blood flow leaking backwards. So patients' legs will typically be more swollen after they've had a DVT. They'll have chronic swelling. They can wind up developing varicose veins. They can have, you know, persistent calf pain. So these are after the clot clears up. These are called post-thrombotic scars. So sometimes this can also be referred to more as a chronic DVT. So you can see after the clot resolves, you get left with this fibrous strand within the tissue, within the vessel. I apologize. So what you look for is these linear echogenic lines. They could be central within the vessel. They can be along the walls of the vessel. This is a good view transverse. You see the linear echogenic line in transverse. So if you were to elongate this, it would probably look like this. So this scarring within the vessel, these post-thrombotic scars, they actually create nice surfaces for new clots to form along. So that's why another indication for doing a lower extremity DVT exam is a patient who has a history of DVT. Unfortunately, once you have a DVT, you become quite more likely to develop a DVT in the future. So the next slide shows calf vein DVT. So like I know a lot of you worry about like being able to scan calf veins and visualize calf veins, and it can be a little tricky. But the good thing is, well, not good thing, but like one of the saving graces is when you get clot within the calf veins, those calf veins become dilated. So that makes it much more easier to visualize the calf veins when they do have DVT within them. So this is an image of the posterior tibial veins. And you can see below it, this is most likely the peroneal veins coming in. So you have your posterior tibial veins more anterior, and more posterior, you have your peroneal veins starting to come in. So then we're going to go into just a couple of other things that you may encounter, you know, while you're doing your lower extremity duplex exam. So you could potentially encounter muscle injury. So when we're in transverse, muscles look vastly different than they do in long, in sagittal view. So if you have any concern when you're scanning a leg, whether something is a muscle or not, go right into your long orientation. And muscle should look striated. So you should get like a linear presentation of the muscle fibers and the muscle tissue. Whereas opposed like a mass or a lesion or something like that, typically won't elongate like that. So the arrows are pointing to the arrows over here are your normal muscle tissue. So over here, you're getting more like a heterogeneous texture. So this could be a potential muscle tear or muscle rupture. There we go. So here's an image of a muscle tear. So this is a transverse view of it. So in transverse, it looks kind of different. It looks like it could potentially be some kind of mass or something like that. You know, it's heterogeneous. You got some anechoic areas. The anechoic areas are most likely blood within the muscle tear. And if we elongate it, you could see your normal muscle fibers over here. You know, it's long striated muscle. And then you get down into the actual tear portion of it. But your long image, you can better appreciate, you know, that it's a muscle. You can visualize the whole muscle here. So this is probably the gastrocnemius muscle. Yeah, so here we go. Hypoechoic area within the gastrocnemius muscle consistent with the tear. Yeah. So another thing that you might encounter are popliteal cysts. So another name for a popliteal cyst is a Baker cyst. That's a common name that you're going to hear in the hospital. So with these, typically you'll get patients that'll, you know, they'll report pain, and pain like not in the actual knee itself, but located posteriorly behind the knee. So the popliteal cysts are basically a fluid collection. It's located posterior to the medial knee, and it's related to inflammation. So typically they're well-defined, rounded, anechoic. You can have some internal echoes and some debris within it. So this is your typical presentation of a Baker cyst. So you can use the term Baker cyst or popliteal cyst interchangeable. So here's one that has some internal septations to it. So you'll see this when you're going down to image your popliteal vein. So in this picture, you could see here's the large popliteal cyst or Baker cyst, and it's going to be more anterior to your vessels. So down here are your popliteal vessels. They're going to typically be deeper. And you can actually wind up with compression of the vessels due to a large Baker cyst or a large popliteal cyst. So here you can see the cyst. It's the whole area. It's very complex. So the whole area of the actual cyst is this. You get more of a cystic component over here with some striations and septations. And then you get more hyperechoic. So this could be more of a hemorrhage area. It's like starting to resolve. And something to note that these cysts can actually become infected. So when you're imaging a Baker cyst, it's important to always put your colored box on this area, just to show, you know, that it's not a vessel, it's not anything, you know, that contains flow, it's not a malignant mass or anything like that, you know. So you want to show that there's no flow central, you know, within this structure. So it's a good rule of thumb to always put your color box in any sort of structure that you're imaging, you know, and to rule out mass or rule out when you're imaging collections, you know, that you may encounter as you're scanning. So you want to check to make sure that there's no vascularity. So if this were to get infected, you could potentially see some color flow around the periphery of it as a result of the infectious process. So other things that you can encounter when you're doing your lower extremity study, abscesses and cellulitis. So these are both caused by bacteria infections. So an abscess or cellulitis in the leg. Cellulitis is an infection of the skin cells. It's usually a result of having a small cut in the skin, and bacteria gets in and infects that surface layer of the skin. So it's a soft tissue infection. The reason you'll often see these, especially cellulitis, is it can mimic the symptoms of a DVT. So you'll wind up with swelling of the leg. You'll wind up with skin erythema, so you'll get redness of the leg. There'll be pain, tenderness. So cellulitis, you don't actually see the physical cellulitis or the infection within the leg, but you'll see kind of like signs of cellulitis. So you'll see a fluid within the tissue, like a diffuse swelling of the soft tissue layer. Whereas an abscess is more of a focal collection. So you'll be able to see an abscess within the soft tissue. So it'll be a well circumscribed collection. So here you go. Here's a good example of cellulitis swelling. So you could see the fluid or within the layers of the soft tissue, and how that surface layer of the skin becomes very edematous, very thickened and swollen. So this is first a cobblestone appearance of advanced cellulitis. So it's diffuse swelling without any focal collection. Whereas an abscess, you can obviously see, it's a well circumcised focal collection. So these are both infectious processes that you could potentially see within the leg. So another thing that you might encounter is lymphedema. So you have two forms of lymphedema. You have primary lymphedema. So this is with patients that are born without lymphatic vessels or lymph nodes. And then you have secondary or acquired lymphedema. So this is a result of trauma to the lymphatic system. So what I mean by trauma is if a patient has a certain type of cancer that invades the lymph nodes, the doctors are going to go in there and they're going to try and remove as much of that cancer as they can, and they might remove lymph nodes. So oftentimes we'll see this, especially with breast cancer patients. So the breast cancer, will invade some of the lymph nodes in the axilla. And the doctors, when they go in and remove the mass or the lesion, they'll take some of those lymph nodes with them. Or even if they're biopsying, they want to biopsy a lymph node, they're disrupting those lymph nodes and damaging that lymphatic system. Unfortunately, the lymphatic system is very sensitive. So, any disruption to the lymphatic system can damage it. And when you damage this lymphatic system, you wind up with swelling in that extremity that drains the lymphocyte, the lymphatic fluid, I apologize. So oftentimes you'll see a patient, with one arm, or I'll get a patient, that have one arm that's typically more swollen than the other. And one of my questions I'll be, like, have you had any sort of breast cancer for a female patient? Did they remove any lymph nodes from this area? Because that could just be, an explanation for why they're having swelling in that arm. This is just showing, the swelling within the soft tissues here. And these are just some more pictures showing some soft tissue edema and swelling. So, and you can see the fluid within the superficial soft tissues, that edema. All right, so now we're going to get into some lymph nodes. So when we're doing the legs, typically we're going to see the lymph nodes in the groin area. So these are the inguinal lymph nodes. In addition to the groin, we can also see them in the neck and the axillary region in the arms. So we'll have our cervical lymph nodes in the neck, and then the axillary lymph nodes as well. Lymph nodes are also seen, throughout the abdomen. They're usually adjacent to the aorta and the IVC and iliac vessels. So you DMS girls, when you're doing some of your abdominal studies, you may notice lymph nodes, along in the right lower quadrant, along like the aorta or the IVC. In general, lymph nodes aren't typically visualized unless there's some sort of infectious process going on, either an infectious process or it could be a malignancy or a cancer. So here we get a normal appearance of a lymph node. So we have a nice echogenic, what's called a fatty hilum. The hilum is the center portion of the lymph node here. They're typically ovoid in appearance. And we get a more hypoechoic or darker area surrounding that echogenic fatty hilum. There is vascularity to lymph nodes, so you will see some vessels feeding these lymph nodes. Typically, it's not hypervascular increase, but there is vascularity to it. All right, so lymphadenopathy. So lymphadenopathy. So this refers to the enlargement of the lymph nodes. So this term adenopathy refers to enlarged lymph nodes. So it can be from inflammatory pathology or neoplastic cancer causes. Sometimes they can cause extremity swelling because the lymph node actually becomes so enlarged, especially in the groin or in the axilla, where you can have compression again and cause that stasis of the blood. So that's another thing that can cause that compression. All right, so malignant lymph nodes, they're typically rounder and they lose their normal architecture. So you might lose that central echogenic fatty hilum. They might look more anechoic, very dark. They typically also have increased vascularity to them. They can become very vascular. So here we're seeing some enlarged lymph nodes.
And they're normal to see in the groin, right?
Yeah.
Groin, armpit, neck.
Yeah. So when you're doing your study, if you notice a lymph node that looks particularly large, you can go ahead and measure it, put some calipers on it, throw color on it, and document. So like when I type up my report, for a lower extremity study, I mention, like I try and describe it sonographically, like well circumscribed structure seen, within the groin of right lower extremity, demonstrates minimal flow with like central echogenic fatty hilum. Consistent with, an inguinal appearance of an inguinal lymph node. Yeah.
So would you consider enlarged like over I think, what do they say, 1 centimeter?
1 centimeter, yeah. So usually the radiologist would like go in short axis, like, anything over 1 centimeter. Yeah, for the groin.
And I would also have to say it's more of like the appearance of it too. Like
Yeah.
when it changes the look, that's when you know that it's the.
Yeah. Yeah, Kathy was saying it's more having to do with like the appearance of it too, You'll learn to recognize when a lymph node doesn't look normal. I mean, especially patients that have cellulitis or an infection in that leg, you're going to see lymph nodes for sure. Or any sort of wound in the leg, you'll sometimes you get wound care patients, they're healing, and you'll encounter those inguinal lymph nodes when you're scanning their leg. So something else that you might find in the leg is a hematoma. So this is actually clotted blood. It's associated with trauma. It can also be from vigorous exercise, from surgery. Could be a result of too much anticoagulation. Patient could wind up with a hematoma if you give someone too much anticoagulation. Their blood becomes too thin and they start to bleed. They may cause pain and extremity swelling. And they can vary in appearance too, depending on how old they are. So if it's a fresh hematoma, it'll look more anechoic. As the hematoma starts aging, you'll start getting more hyperechoic internal echoes and more echogenic internal echoes. And when you put color Doppler, also, it'll demonstrate no flow within it. So this is your hematoma. This is a good example of another hematoma here. So you actually see the layering of the blood. So it's kind of settled. So this was all eventually at one time a pocket of blood within the tissues. That's another thing too. The hematomas occur within the muscular compartment, or it can also be located within the superficial soft tissues. But this is a hematoma within the muscular compartment here. So you can see this is all blood. This is fresher blood that hasn't coagulated yet. And you get a settling and it's starting to coagulate here. So this is actually clot. So this is in the process of starting to resolve. So eventually this is going to become more hyperechoic. And there's really not much that you can do for a hematoma. Just time has to heal itself. Depending on the patient, that could take quite a bit of time. This is more of a fresh hematoma over here, it's more anechoic. You don't have the internal echoes. And this looks more like an older hematoma that's starting to resolve.
So how can you tell the difference between a hematoma and a cyst?
This just has like the 5 characteristics, right? Like the round, anechoic.
Clots, echogenic. Yeah. It's,
Take that one.
Oh, sure. Yeah.
That's all right.
So how I would answer that is that a cyst has all the characteristics of a simple cyst, which would be anechoic, the same dimensions, both like sag and transverse.
True.
So,
Yes.
all of the measurements that you get of a cyst should all be the same.
It's more rounded. Yeah.
Round, thin walls, increased through transmission is what you see below, is where it becomes more echogenic posteriorly. What other signs of a cyst?
Well circumscribed.
Yeah. When you turn the color Doppler on, it's not gonna, it's not a solid area. It's not gonna fill in. So then more of like the hematoma, and you can kind of see how that it takes the space of like the surrounding tissue. So they can kind of have like a more odd, and they could even be like as long as the whole leg. Like I've literally done a panoramic all the way down a leg of a hematoma, And what makes it a hematoma is that it's blood. Heme is blood.
Okay, cool.
Area, a collection of blood. An oma is a collection, so a collection of blood in the calf is a hematoma.
So with that being said, like, because I understand like it can look various. However, but like that bottom picture in the bottom right corner,
Yeah,
like that looks a lot like a cyst.
it does.
That's what I
Like
have.
increase through transmission. Like,
Yep.
so how would we like differ? Like, would it that really just be like the dimensions maybe? Like,
So
Yeah,
we
so
would,
this is probably a transverse view. So if you elongate it, it might look more
Okay.
like that.
okay, gotcha.
and if you remember, our job is just to describe.
Yeah.
So we would know what it looks like. So we would tell the doctor, this is what it measures, this is our appearance, these are all
Yeah.
the things. But
So it's
then
a
we would also know
non-vascular cystic structure seen within, like, the medial thigh.
Mhm. And then a big part that comes into hematoma, is it hematoma versus not, is did the patient have trauma? Did the patient, are they on blood thinners? Is there a reason for there to be a hematoma there versus a cyst? And like a cyst in a calf would be very abnormal. It would be more likely in the sebaceous area or like in the skin layer. And a patient that had a cyst like that in the calf, they would probably need a CT also. So that's all.
Thank you. Alrighty. And we have some soft tissue tumors. So some benign soft tissue tumors include a lipoma, which is the most common. We also have fibroma, leiomyoma, desmoid tumor, neurofibromatosis, and hemangioma. Primary soft tissue tumors include a leiomyoma, squamous cell carcinoma, and melanomas. So we see here with this soft tissue tumor, it's very heterogeneous. It's complex. We have a central anechoic area or cystic component. We have some vascularity to it. We have some peripheral vascularity as well as some more internal vascularity to it. So that's more of a telltale sign of something that could potentially be malignant or a tumor. Is we get in that internal vascularity to it. We start picking up some blood flow within the actual mass itself. So here we see another soft tissue tumor. Again, we see blood flow within the actual structure, within the actual mass or lesion. And typically, it's going to be low resistance blood flow. So we see low resistance blood flow. So we have a high diastolic component to it. That's how we can tell that it's low resistance, and it's typically consistent with more malignant vascularity. So this is a lung carcinoma metastasis. So he had primary lung cancer that metastasized. Well, here we see a very large soft tissue mass. So again, it's very heterogeneous. We get that vascularity with it. So another thing that we could potentially encounter when we're doing an extremity study are joint effusions. So this is a fluid around the actual joints of the bone. So around the knee, hip, we can wind up with hip effusions. We can also have effusions in the elbow and then the shoulder. We can have effusions in the ankle as well. So this is usually results from inflammatory or infectious or traumatic injury to the joint with distension of the joint capsule with fluid. Joint effusion can be differentiated from popliteal cysts by the fluid is confined adjacent to the borders of the patella laterally, medial, and superiorly.
I've got a video if you want me to share my screen.
Sure,
of a joint effusion.
sure.
Oh, I think you have to stop
Oh,
sharing.
yep. All right.
Unmute myself, sorry. You might want to mute yourself.
Yeah, I do.
Okay.
So for me, if I have any question between like a Baker cyst or popliteal cyst and like a joint effusion for the knee, typically joint effusions, you're going to see anterior to the knee. So you're going to be suprapatella. So you have your patella tendon here and you'll be above it. And typically you'll see the fluid more lateral. The fluid's going to be above the knee typically and more lateral. Whereas a Baker cyst, it's typically behind the knee and more medial. You'll be able to see the actual bone in the compartment coming from up here. So if you see a fluid collection like up here, that's going to be a joint effusion. That collection, that central pocket of fluid, like that's well circumscribed, that's going to be a popliteal cyst or a Baker cyst. It's also going to be circumscribed. The joint effusions, you're going to see it like it's really hard to kind of get like, a nice borders on the actual collection itself because it's more progressive. Like it extends out further and it fills the space of the capsule as opposed to being an actual structure itself. That's another thing too to remember with the Baker cyst. It's well circumscribed, it's encapsulated, but that capsule can actually rupture. So if a patient, they twist their knee or they have any sort of trauma, that Baker cyst can actually rupture and leak some of its fluid down the calf. And you can actually sometimes visualize a small channel of fluid running down the calf, and you can track it back up to that original Baker cyst. And it'll actually kind of look like a little deflated balloon almost. But I've seen that where encountered where the Baker cyst is actually ruptured. So the patient will come in and be like, oh, my calf, it's swollen, and I do the DVT study, I don't see any clot, everything looks okay. But I noticed like a small thin channel of fluid running within the muscle, and I can actually track that fluid back to behind the knee, and I can find a small Baker cyst connected to it. And I can reasonably infer that, that patient potentially had a Baker cyst that ruptured.
One other thing I remember, our radiologists at Christiana, when we were proving Baker cyst, we have to show popliteal artery and vein. That was like one of his protocol.
So Kathy was saying that like in Christiana, that the radiologist, in order to prove that it was a Baker cyst, wanted the text to show the popliteal artery and vein in the same image as well. Joint effusions. So other acute venous problems, so recurrent DVT. So this is the development of acute DVT in the presence of chronic DVT. So we saw before that chronic DVT, that scarring within the vessel. This is when a patient starts developing clot on that scarring in that same areas where they've had previous DVTs. Another condition too here is something called superficial thrombophlebitis. So this is when we were referring to the superficial veins in the body. This is the term I like to use to describe clot within, say, the cephalic and basilic veins of the arm and the greater saphenous or the small saphenous veins of the legs. So when we see clot and thrombus development within those superficial veins, this is the term that we will write on our report, the superficial thrombophlebitis. So with that, we get inflammation of the vessel walls. That's that itis portion, inflammation, itis. Thrombo is the clot within the vessel. And then superficial refers to the fact that it's a superficial vein as opposed to a deep vein. So then this talks about just some of the signs and symptoms. You have pain, tenderness, that palpable cord. So we were discussing before, typically you refer that to like, the superficial veins, especially, in the leg, the greater saphenous. Erythema, redness, swelling, inflammation, and induration. That's kind of like the skin isn't smooth, so you kind of see like waviness to the skin. You get indurations in the skin. So the thing to look at with superficial thrombophlebitis is to check to see if there's extension of it into the deep system. So with the greater saphenous vein, when you're up in the groin, let's see, I'm just gonna pause this. Stop share. All right, so you have your common femoral vein and your GSV. So if this is thrombosed here, if we get clot within the greater saphenous vein, you want to check to see if it extends into that common femoral vein. So you could have superficial thrombophlebitis of the GSB, and if it's now extending into that common femoral vein, you now have DVT as well. So a third of the time, you will get extension of that superficial clot into the deep veins. So it's important to look at your junctions. So with the common femoral vein, you look for that junction into you look for that extension of the greater saphenous vein into the common femoral vein. So for popliteal vein, this is your popliteal. So this is going to be your small saphenous vein. Again, look for extension into that popliteal vein from the small saphenous vein. In the arms, we have subclavian vein, so your subclavian vein. And then this could be your cephalic vein. But then you want to make sure that there's no thrombus extending into that. And then we have you also have your axillary and your basilic vein. So it's important to look at those junctions of the vessels. So if I'm scanning and I see clot in the greater saphenous and it's near the junction, I'll actually measure the distance from the thrombus to the actual junction. So I'll put some calipers on there, I'll get a measurement. And my radiologist, if it's less than a centimeter away, then that could potentially be concerning, because you could have clots breaking off from here and then traveling into that deep system and then wind up as pulmonary embolism. So less than 1 centimeter is something that would be concerning. Small saphenous vein or lesser saphenous vein.
Sorry, and what's the cephalic one?
Subclavian vein. Sorry. Yeah.
And then at the basilic and the axillary, something else dives down.
This is a brachial. So this is showing superficial thrombophlebitis at the greater saphenous vein. So this large anechoic one is actual the greater saphenous vein. This is actually what's called a superficial varicosity. So this is actually a small varicose vein that's actually coming off that greater saphenous vein. So this is actually in the distal thigh. So that's a common occurrence when we have thrombosis within these superficial veins, particularly the greater saphenous vein. You're going to wind up with varicose veins, and these varicose veins can then in turn become thrombosed as well. So chronic venous problems, they're mostly due to venous stasis. And the patients develop chronic venous insufficiency, so those valves have become damaged. You're winding up with a lot of reflux, a lot of insufficiency. And when you get a lot of insufficiency, you wind up with a lot of pooling of that blood in the calf, particularly. You wind up with chronic leg swelling. So, the patient will have a swollen leg that just won't go away. It's always going to wind up with a little bit or varying degrees of swelling. It can range from just mild chronic swelling to severe chronic swelling. You can wind up with discoloration, particularly around the ankle. So you can sometimes wind up with kind of like little brown patches of discoloration of skin. You can also wind up, if you have severe insufficiency, with venous stasis ulcers. And also wind up with varicosities or varicose veins. Yeah, this is a better. All right, so this slide shows chronic thrombus with recanalization of the popliteal vein. So this is a patient that's had a DVT that's resolving. So with this image, you're getting flow, partial flow through the vein, and then you still have an area that's partially thrombosed. You see it's very echogenic. You get these linear echoes. And as you progress, so this was 11 months, at 18 months, the vessel starts to become more patent. So you get a more open channel. And the echogenic scar is starting to develop down here. So transverse view, you see more flow getting through in that echogenic scar. So here you see a leg, of someone that's suffering for chronic venous insufficiency. So you get, the leg is very swollen. You have the presence of varicose veins. You have a venous stasis ulcer as a result of that insufficiency. Getting discoloration as well of the leg. Again, here you see some more examples of venous stasis ulcers and the discoloration as a result of insufficiency. And so these are just some slides, going over what we talked about with Virtuo's triad. So this is a good slide actually for risk factors too for upper extremities. So those central venous catheters, those central lines, that we can sometimes see like a PICC line or a central line coursing through the vein, those are nice surfaces for clots to form along, as well as pacemaker leads. And then these are, examples of proximal compression. You have your thoracic outlet syndrome and your Piaget-Schroeder syndrome, as well as compression from malignant masses. So a patient could have like a mediastinal mass or mass, in the central chest that could potentially be compressing, like the SVC or, the innominate veins. Then we have, again, more, this is just for you to review, like I don't expect you to know every single one of these and what they are, just the big ones that we went over, like the factor V, protein S, some of the antiphospholipid syndromes. So another, possible risk factor too is oral contraceptives and smoking. So when a woman's taking oral contraceptives and smoking at the same time, it also can increase the risk for developing clots.
So would that be like a hypercoagulability?
Yes, that would be considered under the hypercoagulable states.
Okay.
Yes. Yeah. And also too with pregnancy too, you have to remember the postpartum period as well. The patient's hypercoagulable, so they're healing. There's the trauma of birth. Oh, that's another one I forgot to add on there. Surgery. You put surgery under hypercoagulable states. So when a patient has surgery, the body, all it knows is like, hey, I just got cut. So it's going to put clotting factors into your body to help you to heal. So post-surgery is it would be considered a hypercoagulable state. So oftentimes, a patient in the hospital, they might administer a low dose of anticoagulation therapy post-surgery. That also depends on the surgery too. If it's a surgery dealing with the brain, they don't want to have, excess bleeding in the brain, or any spinal surgeries. They typically don't introduce any sort of anticoagulation therapy for spinal surgeries, because you don't want blood getting into that cerebral spinal fluid. So you want to maintain that blood-brain barrier. Yeah, definitely put surgery under hypercoagulable states. That's a big one I forgot to add. Again, here's just, risk factors that you can review. So this is another term that you're going to definitely encounter when you're in the hospital, this D-dimer assay. So this is a blood test that measures fibrin degradation products that accumulate in the blood when thrombus forms. So we look for patients that have an elevated D-dimer. So it could be indicative that, that there is the presence of clot. It's not 100%, but it is an indication for an exam to be done. I know, especially with COVID now, whatever the reason is, the nature of the disease, it causes people's D-dimers to be elevated. Patients with COVID do tend to develop clots. It puts them in a hypercoagulable state. So we're in the hospital now getting lots of orders for extremity studies to rule out DVT with COVID patients because their D dimers are high. So when you get into the hospital, like you don't necessarily, as a technician, need to know the actual values, for D dimer range. But just know that a positive D dimer or elevated D dimer could be indicative of clot or thrombus, the presence of clot or thrombus. Mechanism. Confidence. So this just talks a little about varicose veins. So basically the main difference between primary varicose veins and secondary varicose veins is that secondary varicose veins are caused by reflux or obstruction of the deep veins. So you're getting that back up into the superficial system. It can also be from having incompetent perforator veins. So this is just a slide showing, the mechanisms of that calf muscle pump, that the veins require that skeletal muscle contraction, to circulate. Yeah, Lily was so super detailed with everything. Holy gosh. And yeah, so you could see, these are ugly varicose veins.
Are the, like, you hear people call them spider veins, like the really tiny ones? Are they kind of like the same thing as varicose, just not as big?
No, these varicose veins are these large dilated ones.
Okay. So the spider veins, like what are they called? Like the little one,
I mean,
know.
those are more like little small superficial like vanules.
Yeah.
Those are like,
So they're just really superficial.
yeah.
Okay.
All right. All right, so this is actually an important slide for medical treatment for DVT. So this is probably some questions that might appear on your board exams. So anticoagulation therapy or anticoagulation. And the main thing to remember with anticoagulation is the medicines that we give, they're to prevent clots from forming and not actually breaking up clots. So lysis is the destruction or breaking up of clots. So these medications that we give when the patient has a blood clot in the hospital, we're not actually, giving medications to dissolve or break up these clots. It's to prevent new ones from forming. So the body itself is what's gonna break down these clots and eventually get rid of them. So the main medication that we give is heparin. Typically, it's intravenous heparin. So if a patient has, a substantial DVT, they're going to administer intravenous heparin for, about a week. And then they'll follow it with an oral medication like Coumadin, which they'll have to follow, once they get discharged for a period of time. In some patients, they may be on lifelong anticoagulation therapy. So some other medications here, that you might hear of that are similar to heparin and similar to Coumadin are Lovenox. So my wife actually, with our last pregnancy, we had a miscarriage in between, and her OBGYN actually ran a series of blood work on her and discovered that she had a protein S deficiency, so one of those clotting factors. And actually started her on subcutaneous Lovenox. So this is actually an injection that you give in the belly or in the arm. And she had to take one shot every day throughout her pregnancy, just to ensure that she didn't develop, blood clots, because it could potentially be, an issue for her as well as to the fetus itself. So we were thinking that it was possible that for that miscarriage that we had in between our two kids, that potentially the placenta developed clots within those vessels and could have led to that. We don't know for sure, but that's just one theory that we were thinking about, with her OBGYN. So Xarelto is another common medication that you might hear patients being on. Those are the three big ones, or four big ones: heparin, Coumadin, Lovenox, and Xarelto. So thrombolytic agents. So these are medications that we can give that can actually break up the clots. So there are medications that do break up DVTs, but they're not commonly used. And these are reserved for critical situations where a patient has, very, very extensive DVT, that's coming all the way up the legs, up the iliacs, getting into that IVC. And this is a surgical process to administer these thrombolytic agents. So this is typically done by an interventional radiologist, where they would take the patient, they'll insert a catheter into the groin, into the vein, and they have a needle that actually administers the medication, and they kind of go up the vessel, up the thrombosed vein, administering this medication that breaks up the clots. Oh, 2 minutes. All right, sorry. 2-minute warning. I think we're almost done.
And if you could just ask them if they wanted to stay on, we can talk about lab times for Thursday.
Sure, yeah. So Kathy just wanted to know if you guys can stay on for a minute, and just talk about lab times. So just quick, another surgical treatment you might hear actually is the administering of an IVC filter. So certain patients, particularly cancer patients that are prone to developing these clots, or stroke patients where they can't administer anticoagulation therapy, or patients who have brain surgery, they may put in a filter in the inferior vena cava, usually just below the level of the renal veins, to catch any clots that may travel up. This is in order to prevent pulmonary embolism, as well as preserve some of those vessels, particularly the renal veins. You don't want clot traveling into those renal veins, compromising the kidneys as well. So here you can see some various types of filters. More common one is the Greenfield filter. And here's an image showing actually the filter in the inferior vena cava. It's an IVC filter. We don't need to go into that right now.
So I do have a question. So I know next week we're supposed to have a test. Is this test going to be on what we're doing today, or is it going to be from like on next week's lecture too? Because I know.
No, it's going to be just what we're doing today. Yeah,
Just
just
okay.
this lecture.
Okay, perfect. Just making sure.
Yep, no, just this lecture. That's it. Yeah, it's not going to be long. It's just basic. Like, I just want to make sure you guys know the anatomy, basically, you know, and that's the main point. Know the anatomy, know what's superficial, know what's deep, know the difference, you know, like characteristics of veins. You know, veins have valves. Veins, you know, have thin walls. You're able to compress them easily. Pressure's lower in the veins, you know. And then basically, you know, causes of DVT, signs and symptoms of DVT.
Okay.
Yep. Okay. All right. So I think that's it. I think we're good. So stop sharing.
Thanks, Dan.
Yeah, I couldn't. I sat down this weekend with all these PowerPoints. I was like, I can't do this. Like
No,
I'll be honest with you. I had flashbacks to some of my programs, and like I remember, like I'm not an OBGYN guy, no offense. But like I remember sitting in some of those lectures. I'm like, holy moly! Like even in I was live, you know, and our PowerPoints were like, you know, 200 slides like this. And I'm dark room, like nice and quiet. I was like, oh, this is brutal. But unfortunately, that's just kind of how the nature of ultrasound is. You know, it's a lot of information that we have to learn, and we're just throwing all this information at you. You know, and it's tough. Like I don't think people really appreciate just how much we have to learn for ultrasound. You know, it's a lot for sure. Yeah.
Well, I will say I personally love today's lecture, and I feel like I actually really learned like a lot. Like I've got like pages and pages of notes, and like
Yeah,
honestly,
that's what I want. Like that's what I was.
yeah, usually after 3 hours, I lost focus. I didn't even get notes for the last half, but like I actually paid attention the whole time.
I agree. Same.
And I'm a stander. I hate to sit. Like that drove me crazy sitting at the desk. Like I like to pace, walk around, move. Like I don't know.
Can you see my screen?
Yeah, I can see you.
Yeah, you're good.
Yep.
Ah. Oh my God.
Now I can't.
Sorry.
Vanished.
Sorry. Okay, so I just wanted okay, sorry. Can you turn the volume down on the speakers? Yes. Okay. Can you guys hear me okay?
Yes.
Okay. So I was just kind of playing around with like the different groups because I know in talking to you all, we can make like smaller groups. And I know some people were wanting to switch like from the more like morning time to the afternoon. So we can kind of like work through this. We'll definitely do like a more of an echo. Look at this, Sudan. Like the echo, like 2 to 4 would be like a dedicated kind of echo time. And I figure whoever's in the echo portion we could be doing abdomen on the other two machines. Kind of like we worked with having this, everyone together.
This would still be on Thursdays,
What do you guys
correct?
think about this?
Kathy, would this be on Thursday still?
I can't hear you. Sorry.
Would this be on Thursday still?
Oh, yeah. Thursdays.
Cool. Just checking.
Yeah. And then I was looking at like the lab schedules on like the banner system in the SIS too. So kind of trying to see what maybe you would have preferred before. So like these were kind of like the maybe could swing up to the beginning time that may have been in the afternoon time with the, with Echo needing all three together. So do you want to go through, like Megan, what would you prefer, day or, like more like the morning, or stick with the afternoon?
I kind of feel like I'm just trying to think.
Yeah, exactly. Yeah.
If I have to go into work, I would prefer just to come in the afternoon and be there for 4 hours straight. Like that's just me.
Okay. Cool.
Just because that makes me, I can do things at home and then come up that way.
Mm-hmm. Okay. What about you, Kim? Were you still thinking about coming up more to like the day?
Yeah, I mean, I think I would definitely want to stay there, kind of not like break it up, but
Oh yeah, I have your name everywhere.
I see that.
I'm like, Kim?
Yeah. I mean, I could probably do like the like 1 and 2 vascular and then 2 to 4 abdomen. I mean, that's probably fine.
Cool.
Because I might like go into work in the morning now or something. I'm not really
There you go.
sure. So
Yeah. And they were actually saying that like with the I-95 things, that like more of like mid-afternoon is obviously going to be better for traffic. So that probably would be better, for you to get here at that time.
Yeah. Yeah. I mean, I know I'm not the furthest, but I'm, like I said, 35 minutes without traffic. So that it might work out a little bit better.
Cool.
If
Okay,
I do
good.
it that way.
Okay, great. And then just let us know if it's, if you want to switch, whatever. What about you,
Okay.
Denisha?
I like the afternoon.
Okay.
So like vascular 1 and 2, and then abdomen 2 to 4.
Yep.
Kathy, I also don't mind, like if it gets really full in the afternoon, then I can study in between. Like, so I don't mind, honestly.
Okay.
I'll make it work if, I don't have to be all in the afternoon if that works better for other people.
Okay.
And I'll say that I live really close. It's Morgan. So like I can come in the morning and I have no problem coming back again at 2.
Okay. How about you, Lauren? You're good staying in the day, right?
Yeah, I would prefer to stay in the day just in case I work at night.
Okay, good. Kristen, what about you? Kristen, sorry.